All right, everybody, Dr. Rafich here from Vet Triage. This is going to be posted on January 26, 2025. We are going through this issue of JAVMA. This is from March 15, 2017, and we are going to be talking about this paper, Accuracy of Point-of-Care Lung Ultrasonography for the Diagnosis of Cardiogenic Pulmonary Edema in Dogs and Cats with Acute Dyspnea. For those who don't know about ultrasound, that picture below shows a lady with a cat, and there's abdominal ultrasound there. They have the all different probes usually on the side of the ultrasound here, and there's the keyboard that controls all the settings, and then of course the display up here, and they can record ultrasound in real time to have it evaluate either there, or they can send the images out to a radiologist who can interpret them for them. This study comes out of the vet school in North Carolina, as well as a specialty hospital in Texas, and an Iowa State University vet school. The objective is to determine the accuracy of a point-of-care lung ultrasonography protocol designed to diagnose cardiogenic pulmonary edema in dyspneic dogs and cats. 76 dogs, 24 cats. Results were dogs and cats with a final diagnosis of cardiogenic pulmonary edema had a higher number of positive lung ultrasonography sites than those with non-cardiogenic causes of dyspnea. Overall sensitivity for the ultrasound for cardiogenic pulmonary edema was 84%. The specificity was 74%, and these values were similar to thoracic radiographs, which had a sensitivity of 85% and a specificity of 87%. Use of the ultrasound led to misdiagnosis of cardiogenic pulmonary edema, meaning a false positive, in animals that had diffuse interstitial or alveolar disease. The inter-observer agreement for ultrasound was very high. Okay, introduction. Lung ultrasound can be conceptualized as a visual stethoscope that can be used to supplement auscultation and improve the diagnostic accuracy of the physical exam before thoracic radiographs. The ultrasound technique can be used to detect pulmonary edema through the identification of ultrasound artifacts, are called B lines, B as in boy, also called rain down artifacts or comet tails, lung rockets, and other terms. And it's caused by an increased amount of water in the lungs. The B lines, which is terminology advocated in the recent international consensus statement, are created when fluid-filled alveoli, which are below the resolution threshold for ultrasound, are surrounded by air, creating a high impedance gradient. These artifacts are identified ultrasonography as discrete, narrow-based, vertical hyperechoic artifacts that extend from the pleural pulmonary interface to the far aspect of the ultrasound screen without fading, and that move synchronously with respiration. Findings in human emergency patients suggest that ultrasound can be used to differentiate cardiogenic versus non-cardiogenic causes of dyspnea with fairly high sensitivity and specificity, and similar or greater positive predictive value than measuring blood NT/pro-BNP concentration. That acronym is N-terminal pro-B type natriuretic peptide, or using thoracic radiographs. The number of B lines is positively and linearly correlated with the amount of lung water and pulmonary capillary wedge pressure. Two studies show that B lines are fairly rare in normal dogs, but are common and widely distributed in dogs with cardiogenic pulmonary edema. Regarding materials and methods, this study was from 2013 to 2015. Ultrasound exams were performed by use of a single portable ultrasound machine with a curvy linear probe with standardized settings, ultrasound frequency of 8 megahertz, and a depth of 4 centimeters. And that has to do with the probes they have. There are different types of probes. Patients were standing position or position in sternal recumbency. Images were acquired at 4 acoustic windows on each side of the thorax, and that's shown in the thumbnail there of how they had the 4 windows. For each, the anatomic sites were caudal, perihilar, middle, and cranial, for a total of 8 sites per patient, so 4 on each side of the chest. For each site, the hair was parted but not shaved. Alcohol was applied. The maximum number of B lines visible within a single intercostal space at each of the 4 anatomic sites in each hemithorax was recorded as 0, 1, 2, 3, or greater than 3, or infinite. infinite being confluent and no longer discernible as individual B lines. In accordance with the Volpicelli method, which is endorsed in a human ultrasound consensus statement, these exams resulting in at least 2 positive sites on each hemithorax were defined as being consistent with cardiogenic pulmonary edema. The lung ultrasound exams with less than 2 positive sites on each hemithorax were consistent with non-cardiogenic cause of dyspnea. Specifically, the following additional definitions of cardiogenic pulmonary edema were considered: ultrasound that revealed at least 2, 3, or 4 total positive sites regardless of distribution, and ultrasound results that revealed 2, 3, or 4 positive sites requiring that at least 2 positive sites are perihilar or caudodorsal. So this is a close-up of that picture with the dog and the probe and all different images there, and how they characterized it. If you want to pause the video, you can look at the captions. For determination of diagnosis, radiographic findings of cardiomegaly and interstitial to alveolar pulmonary opacities with perihilar to caudodorsal distribution in dogs, or with a localized or diffuse distribution in cats. When radiographic diagnosis was uncertain, pets with echocardiographic findings compatible with acutely decompensated heart failure, like acute chordal rupture or infectious endocarditis, vegetative lesions associated with severe valvular regurgitation, a positive clinical response to heart failure treatment, a markedly high blood NT-proBNP concentration of over 1,500 pgs per ml for cats, or postmortem findings would also meet the criteria for the diagnosis. Patients that did not meet the criteria were determined to have non-cardiogenic causes of dyspnea. Results: mean age was 9.7 years old. 31 dogs were, so most dogs were spayed females or castrated males. Cats, mostly castrated males. Mean body weight for cats, 5.7 kilograms. For dogs, 14.8 kilograms. Domestic short hair was most common for cats. For dogs, it was Dachshunds, Cavalier, King Charles Spaniels, and Chihuahua. Regarding the ultrasound examination, the mean between performance of ultrasound and thoracic radiographs was 1.63 hours. So they were spread 1.63 hours apart on average. 82% of patients were received at the hospital through the emergency critical care service. 68% of ultrasound was performed by a single examiner. And that could be a problem. I'm not sure. You kind of want to have the lowest number of examiners, ideally maybe 1 to keep it standard, or if you're going to have multiple examiners, have them all do equal amounts of cases each and over a larger population of animals. 61% of patients had a diagnosis of cardiopulmonary edema, 39% non-cardiac. The proportion of patients with cardiac pulmonary edema, or cardiogenic rather, did not differ between cats and dogs. Cats 62%, dogs 61%. Causes of cardiogenic pulmonary edema in dogs were degenerative mitral valve disease, dilated cardiomyopathy, aortic valve insufficiency from endocarditis, and causes in cats were hypertrophic cardiomyopathy with or without obstruction and unclassified cardiomyopathy. Lung ultrasound resulted in identification of at least 1 positive site, which meant over 3 B lines per site in 90% of patients with a cardiogenic pulmonary edema diagnosis, with a mean of 5.3 positive sites per patient. In contrast, ultrasound results in identification of positive sites in only 26 of 39 patients, so 67%, with non-cardiogenic disease, with a mean of 2.7 positive sites per patient. Patients with cardiogenic pulmonary edema had significantly higher number of positive sites than did patients with non-cardiogenic disease. Overall, positive ultrasound scores were more common on all sites in patients and dogs and cats combined with cardiogenic pulmonary edema than those with non-cardiac disease. Overall distribution of positive sites differed significantly between these two groups. For patients with cardiogenic pulmonary edema, the most common positive sites were right and left middle sites. Non-cardiogenic right middle alone was most likely to be scored as positive. For both groups, right and left caudal sites were least likely to be scored as positive. This is a picture here of the different fields. So 4 on each hemithorax. A is cardiogenic pulmonary edema, B is non-cardiogenic. Regarding accuracy of ultrasound for diagnosing cardiogenic pulmonary edema, overall sensitivity and specificity of ultrasound with the cutoff used, so at least 2 out of 4 anatomic sites deemed positive for each hemithorax. Dogs and cats with acute dyspnea, 84% for dogs, 74% for cats. The ultrasound was a highly significant predictor of final diagnosis. For cats specifically, the sensitivity was 87%, specificity 89%, dogs 83% and 70% respectively. In comparison, overall sensitivity and specificity for thoracic radiographs for diagnosing cardiogenic pulmonary edema was 85 and 87% respectively. Diagnostic accuracy of ultrasound versus thoracic radiographs was summarized. When all patients with an initial heart rate of less than 150 beats per minute were reclassified as having non-cardiogenic disease, specificity for ultrasound for dogs but not for cats improved to 87%, but it made sensitivity decrease to 52%. Additionally, heart rate failed to significantly improve the accuracy of ultrasound for the diagnosis of cardiogenic pulmonary edema. Respiratory rate, rectal temperature, and murmur characteristics had no effect on the diagnostic accuracy of ultrasound. Regarding inter-observer agreement on ultrasound results, the inter-observer agreement between the experienced and inexperienced examiner on results of ultrasound was excellent. Inter-observer agreement for scoring individual ultrasound sites as positive versus negative was also excellent. For 6 of the 8 sites, the correlation was very large, indicating almost perfect agreement. The final ultrasound diagnosis of cardiogenic versus non-cardiogenic pulmonary edema differed between observers for only 6 of the 100 patients. Okay, discussion. In the present study, the overall sensitivity ultrasound for diagnosing of cardiogenic pulmonary edema in dogs and cats with acute dyspnea was good at 84%, and similar to the 85% for thoracic radiographs. For cats in particular, the sensitivity of ultrasound was even higher at 87%. Previous studies of ultrasound in dogs identified high numbers of B lines and positive ultrasound sites in every dog with cardiogenic pulmonary edema in which ultrasound was performed, which would suggest 100% sensitivity. Sensitivity of ultrasound for cardiogenic pulmonary edema in this study was slightly lower than human studies of the diagnostic accuracy of ultrasound, in which sensitivity was ranged from 81.3% to 98.3%, with a mean sensitivity of 94.1%, and the absence of B lines in all quadrants ruled out cardiogenic pulmonary edema. The overall specificity of ultrasound for ruling out cardiogenic pulmonary edema in patients with non-cardiac disease was also good at 74%. For cats, specificity of ultrasound was excellent at 89%. Previous study of ultrasound in dogs have identified very low numbers of B lines or positive ultrasound sites in normal dogs, which would suggest 100% specificity in differentiating clinically normal dogs from dogs with cardiogenic pulmonary edema. The mean number of positive sites, over 3 B lines per site for dogs with non-cardiac disease, 2.7, was higher than the total number of B lines, so the sum of all sites reported for clinically normal dogs, which is 0.9. For both dogs and cats, ultrasound resulted in correct categorization of all patients with upper or lower airway disease, neurologic disease, unknown cause of dyspnea as having non-cardiac disease. False positive ultrasound results were more likely to occur with patients that had diffuse interstitial alveolar disease, including acute respiratory distress syndrome, pulmonary cancer, pneumonitis, pulmonary hypertension, or suspected pulmonary fibrosis, and pulmonary thromboembolism. However, ultrasound could not be used to differentiate among the types of interstitial or alveolar infiltrate, meaning cardiogenic edema versus inflammatory cancer, non-cardiogenic, or hemorrhage. The specificity of ultrasound was lower in dogs at 70% in this study than in cats, 89%, and was also lower in dogs than in humans, which was 84.2 to 96.4%, with an average of 92.4% in humans. In humans, the most common differential diagnosis for acute dyspnea includes cardiogenic pulmonary edema and chronic obstructive pulmonary disease, or COPD. In the dogs in this study, the specificity of ultrasound at 70% was lower than thoracic radiographs at 87%, although these values were equivalent in cats at 89%. Other point-of-care diagnostic tests that may be used in series with ultrasound include measuring cardiac biomarkers, so NT-proBNP, and measuring the ratio of left atrial dimension to aortic diameter on focused echocardiographic examination. The Volpicelli criterion used to find a positive ultrasound result in this study requires a bilateral distribution of cardiogenic pulmonary edema, so at least 2 positive sites on each hemithorax. Cats are more likely to have a diffuse or multifocal distribution of cardiogenic pulmonary edema. Dogs with mitral valve disease and an eccentric jet of mitral regurgitation are more likely to have focal cardiogenic pulmonary edema affecting right or left caudal lung lobes or both, and dogs with dilated cardiomyopathy and a central jet of mitral regurg are more likely to have a symmetric perihilar or caudal distribution of cardiogenic pulmonary edema. That's just saying that you can't always get bilateral edema. It depends on the disease. Diagnosis of cardiogenic pulmonary edema was best predicted by the Volpicelli criterion, requiring bilateral distribution and at least 50% of total lung sites affected. These distributions of positive ultrasound results in the present study suggest that the middle lung quadrants were more commonly affected, regardless of whether patients had cardiogenic pulmonary edema or non-cardiogenic disease. The optimal reference standard for differentiating cardiogenic versus non-cardiogenic would have been assessment of pulmonary capillary wedge pressure. Finally, the performance of ultrasound is dependent on several equipment-related factors, including ultrasound model, probe software, and the quality of the ultrasound training. So that's it. I mean, kudos to a pretty good study. Obviously, you want more animals, maybe have less observers, or have more observers with more animals between them to increase the accuracy of this. But these studies are very difficult to write, and this was quite impressive that they were able to do it. So, yeah, thanks to those who watch and support the channel. We'll see you next time. Bye-bye.